The way that this drug works is to hold your immune system in the lymph nodes. So instead of blocking it at the sort of brain level, which is what Tysabri does, it holds the immune system in the lymph nodes. So the side effects of it are quite different. It has a more systemic effect on your body, so people are more likely to get viruses. And viruses not only in the brain, there have been a couple of cases of the PML, so the viral brain disease, but it's viruses in the body that are a problem as well on this drug. So we check everyone has been exposed to the chickenpox virus before they start, and if they haven't, we immunise them. We check, you'll see your doctors will do hepatitis screen, HIV screen, so you get a sort of general viral body screen to make sure you don't have a virus in your body that's going to be made worse by that drug. And when you're on the medicine, it's important that if you are getting viral infections that you talk to your doctor or ring the MS nurses about it. And the reason for that is that we can stop this medicine very easily. So you just don't take the tablet for a week or two until you've recovered from your virus. And there have been some patients on this medication, not in New Zealand, but as part of the trials, there was, I think, one patient who died from a disseminated virus. And that was because they didn't stop the tablet. And I think it's the mindset, you know, we get so, and it's great to have these treatments because they work, but at the same time, a virus is something that your body can fight when not on the medicine. So it's really important if you do get sick, don't just wait and wait and wait. Ring up the MS nurses, talk to your GP, I've got a virus, is it okay if I just stop the medicine for a while? I think the other reason why this drug is a little bit dangerous from a viral point of view on the stopping front is it has effects on the heart. And so when you first start the drug, you take it in hospital for 6 hours and you sit there, and it's probably not a very enjoyable experience, probably quite boring, sitting there waiting for your 6 hours to go by and monitoring your heart to make sure that it's not going slower and there's not any changes in the ECG. And then from the first time you take it, you have to take the medicine at the same time of day for 2 weeks, otherwise you have to come back in hospital and start that again. Once you go past 2 weeks, then you're actually fine to miss a dose here and there. I mean, obviously, ideally from an MS point of view, you'd take it every day. But if for some reason you needed to stop it or you missed a tablet, it's not the end of the world after the 2 week mark. And so from a viral point of view, if you get sick from a virus, once you've been on it for a year or two, you could stop it for 2 weeks, and then as long as you start within the 2 week frame, you don't need to come back into hospital. But even if you have to come back into hospital for 6 hours, you know, it's better than letting a virus kind of take over. So the side effects from the heart point of view are it's thought to be a first dose effect rather than an ongoing effect on the heart. And so when you take the first dose, you need to be in hospital and monitored. We haven't had any problems at Auckland Hospital yet, but there can be the potential that it will dangerously slow your heart. In everyone, it does slow your heart. So if you're sitting in the mid-50s, you'll probably go down and you may go into the 40s, which is quite low. It drops it on average by about 8 beats per minute. So you can kind of calculate that out and imagine where you might end up. But as long as your blood pressure's fine, you're fine, your heart tracing's fine, then you just get observed and things come back to normal and you go home again. The other weird thing it does is cause a collection of fluid behind the eye, but that's again something that's rare. It's less than 0.5%, and it tends to be something that happens at an anticipatable time. So it tends to happen about 3 or 4 months after you first take the tablet. And so because of that, we've got a way of screening the back of the eye looking for that fluid accumulation. In a lot of places around New Zealand, they're not doing a baseline. So they're not getting a screening test before, they're just checking at 3 months. But in Auckland, because we've got such good access to that type of screening test, most people will get a before, so we know if you've already got a bit of fluid, and then if at 3 months you've got a bit of fluid, we know that you already had a bit of fluid, so it's fine to keep going on the drug. So it's if you didn't have fluid and then 3 months later you've got fluid, you may have to stop the medication. But that happens very infrequently, but we do this so people are safe. Yeah, that test, once you get through the first year, most people just will have to take the tablet every day and see their doctor once a year. It's very well tolerated after the first year. In the first year, the other thing that can happen is it can drop your white cell count really low. So some of you in this room may have started on it and you get the call from the MS nurses saying, your white cell count's low, you need to take it every second day. And the other thing that can happen is your liver function can go up. And if your liver function tests go up, then you need to drop to every second day dosing as well until it comes back. But those are just sort of blood test abnormalities. They shouldn't cause you any harm, but it's just as part of starting the drug, it can cause those things. So the first year is full of all of that, and it's quite a lot, but once you get through all of that, from the 1 year mark onwards, it's pretty smooth running for most patients. And it's very effective. It's nearly as effective as Tysabri, reduces relapse rate by about 60 to 70%, and it has good disability data and good MRI data showing that there's not a lot of accumulation of new lesions. Before the break, I might just talk about the 2 other new drugs. Is that all right, Trace? Or yeah. So we're hoping to get fumarate, which it was meant to kind of already be here, but it's not here yet. The other name for fumarate is Tecfidera. It's an old, it's a medicine that's been around for a long time. It was originally developed to treat psoriasis. And I remember talking to Dr. Willoughby when they were running the trials. There's some patients in Auckland that did the original trial of this drug. And it wasn't expected to do very well. I remember Ernie being absolutely amazed at how well the trials came out from this drug, because it was sort of borrowed from psoriasis, and borrowed drugs don't usually do that well. But this one has done really well. It's tolerated reasonably well because it's a tablet. It can give people hot sort of sweats and flushing, and it can cause some stomach upset and diarrhea. So it's got this sort of gastric and flushing problem, but that is able to be managed with a very slow introduction to the tablet. And once you're on it, most people, again, once you get through that first part, most people do feel very well on it. So those are the good things about it. It doesn't have a lot of side effects. Again, there have been a few cases of patients getting the PML, so the brain infection can still occur on this drug, but that's very much rarer than Tysabri. And the other not so good thing about it is that it's not quite as effective. So it sits somewhere between the interferons and the fingolimod Tysabri. So for patients who, the place where it's probably going to work really well for us is for patients who are first diagnosed with multiple sclerosis, where you're not quite sure how their disease is going to be, or for patients who the complexity that is the fingolimod tablet and all the potential side effects is quite a lot, or for some reason they're not able to have fingolimod, or a JCV positive person who can't have the Tysabri, but whose disease isn't very aggressive. So the reason why it would be really nice to have available in New Zealand is because it sits really well in that kind of middle space, where at the moment we're very skewed. We've got highly effective with complex side effects and not a lot of side effects, but not great efficacy. So having it in the middle would just be really, really great. So for those of you who are newly diagnosed, contemplating treatment, fumarate is a good option, and hopefully, what are we now, August? People promise me we'll have it by January next year, so fingers crossed. The other medicine that's really exciting is Lemtrada, so that's alemtuzumab. It's been approved and they have it available now in Australia. In terms of timing in New Zealand, I think it will still be years away. The reason why I am particularly keen for us to have that drug is that it sits kind of beyond fingolimod and Tysabri, and that it's very, very effective. But its side effect profile is, again, beyond Tysabri and fingolimod. It's got very serious side effects to it. There are patients who have had treatment with that drug in New Zealand because they've had it in Australia and come to New Zealand. And I think its use is going to be slowly increasing. The place where that fits is also for people who are JCV positive. So if you're JCV positive and for some reason fingolimod doesn't work, or you can't have fingolimod but you've got quite aggressive disease, then Lemtrada is probably the best drug. And I know in Australia they're starting, anyone who's JCV positive, at the beginning they're thinking about whether this is the right medication for them. So anyone who's an Australian citizen, it's probably a good idea to go and talk to an Australian neurologist about Lemtrada. But for us in New Zealand, it's a very expensive medicine. It's something like $120,000 for a course of treatment. So it's not the kind of thing that people can afford to pay for themselves. The way that it works is, again, really different. And from a wellness point of view, it's as close to sort of a curative medicine as you can get, because it's given once over a period of 5 days at the very beginning. And then you don't have any treatment for a whole year. And then you have 3 days. And then potentially that might be it forever. Some people need another treatment several years down the track. So you can imagine that if you've had that, once you're finished that infusion, you don't take a drug, you don't take anything that reminds you of your disease process every day or every month. So how it works is it's infused like natalizumab or Tysabri, and in your body it annihilates all your immune system. So it just takes out your B cells and your T cells, but what it leaves behind are your own body's stem cells, so the cells that can grow back into immune cells. And so basically it just wipes your immune system clean, says start again, and then your immune system grows back. And it grows back in a way that is beneficial from an MS point of view, in that mostly these patients don't have relapse events. But the downside to that regrowth is the cause of all the complications. And as your immune system starts growing back again, it sometimes gets out of balance, and so patients can get immune side effects. About 25% of people get thyroid disease. So you've gone from someone who has MS to someone who has MS and thyroid disease, or someone who has MS and also has low platelets because there's antibodies to the platelets. So it does bring with it lots of potential problems. But in saying that, it's very effective. In terms of, I know that the drug company that own this product are currently looking at bringing it into New Zealand and sort of the potential for us to have it. But that, as we all know from the Tysabri fingolimod story, is a very long, drawn out process. And so it will probably be several years away, I would think, unfortunately. So I might stop and we have a break and then come back. And then after the break, we're just talking about the criteria for the new medicines. And I'll try and whiz through that so we've got plenty of time for questions.
After you choose